Next case is a 52-year-old male patient with a history of known case of diabetes mellitus for 20 years. And he is having a non-healing ulcer in the left sole with foul-smelling discharge and pain.
Okay.
So,
He posted for debridement.
it's not given whether he's posted for debridement or
Okay.
not. So,
Now I am telling you, he's posted for debridement. How are you going to manage the patient? Straight away, we'll go to the discussion.
okay, sir. Sir, first, in history, I would like to ask some other questions in
No,
these
tell me
papers.
straight away. Don't be elaborate like this. What do you want to ask in the history? Tell 1, 2, 3, 4 like that. Don't use any long sentences. Avoid
Okay.
that habit.
I would like to ask whether he has any fever, chills, rigor, to see
Okay.
if
Why you want to ask that?
he has any septicemia.
Very good. Excellent. Foul smelling discharge, infection, septicemia. Excellent. Then, what other questions you want?
Then I would like to ask any history of bowel or bladder disturbances, any history of um, um, any constipation or diarrhea history before.
Bowel and bladder disturbance means the same thing. Ma. You are beating around the bush. Why you want to ask that?
To ask for diabetic autonomic neuropathy, sir.
See, so first thing always you must say is because he is a long-standing diabetic, I would like to inquire about diabetic status. What is the diabetic control? He has not had any control. That is why he has landed up with a wound infection, isn't it?
Yes.
So
Yes,
I
sir.
would like to know about how his diagnosis was treated all these years, whether he has been regular with his treatment, whether he was good in his follow-up,
Yes, sir.
why, how this wound developed, was there any injury, is there any pain in the wound? Supposing patient has a painful ulcer, another diabetic patient has a non-painful ulcer. What is the difference between the two?
That is, the patient has peripheral neuropathy, then the patient will not have pain. If the
Pain.
patient
So
has
absence of pain indicates a
peripheral,
sensory neuropathy. Okay.
yes,
Whereas the pain is a good sign that patient still has a intact sensory nervous
peripheral,
system. Okay.
yes, sir.
So the most important question that you would like to ask is find out is whether the patient has developed diabetic autonomic neuropathy. So for that, what questions you would like to ask?
Uh, I
You
will
said
ask whether
about
he
bowel
has
and bladder. That is the last thing, but more important than that.
orthostatic hypotension.
Very
Uh,
good.
then I'll ask whether he has any bloating after eating, to know about gastroparesis.
Very good. Excellent. Then male
Then
patient.
um, erectile dysfunction.
Very
Uh,
good. Third. Then
um,
bowel and bladder. All these things are the clinical indicators of diabetic
autonomic.
autonomic neuropathy. Okay. So
Yes.
you would like to, why you are worried about diabetic autonomic neuropathy in this case?
The If the patient is having autonomic neuropathy, then there will be more hemodynamic instability in the patient after giving the anesthetic drugs, or even after spinal neuraxial blockage.
Very
Uh,
good. Very good. So patient may be difficult to treat from the spinal hypotension that you may plan to give commonly used in these cases. Okay, very good, right. What is the other important complication because of this infection? One is sepsis, you said. What is the other
yes.
important complication that may be present in this patient? Whenever there is stress or infection or sepsis, what is the metabolic derangement that the patient can develop?
They can have acidosis, metabolic acidosis.
What acidosis?
Uh, Metabolic acidosis.
Diabetic ketoacidosis, DKA. Please mention that word. That is very, very, very important. Any wound infection patient, chronic diabetic coming for any leg procedure, always rule out not simple acidosis, diabetic ketoacidosis. You must know in and out of DKA in the exam.
Yes,
Okay,
sir.
you must read it thoroughly and remember every point. They will not excuse you if you make any mistake in DKA management or the causes. Okay.
Yes.
So what are the features of DKA?
Uh, It is the patient will have dehydration. There
Very
will
good.
be sugars will be more than 250 milligram per deciliter.
Hyperglycemia.
Hyper,
Don't mention any value, ma. It may be 400, it may be 300. So just say hyper dehydration, hyperglycemia. Then
bicarb will be less. Uh,
again
then
you
the
are
patient
saying
is
high anion gap acidosis. Straight away hit the nail. Don't
yes.
beat around the bush. Three things: dehydration, hyperglycemia, high anion gap, metabolic acidosis. These are the three things you must answer. Clear answers. No saying bicarb will be less and hydrogen ion will be more. That is not the way to answer. Your answer should be very clear cut. Okay, so that the examiner gets impressed by your answer. So these three things are there. Dehydration is why dehydration happens. What is the pathophysiology? Why patient becomes dehydrated?
Because of hyperglycemia, there will be
Very good.
dilutional osmotic diuresis.
Mhm. Not
So,
dilutional and all that. High sugar itself is an osmotic agent, so it will cause more. So
diuresis.
initially, patient will have large urination or diuresis, then lead on to dehydration. So by the time he comes to you, he is dehydrated because he has volume depleted, right?
Yes.
Okay.
Yes.
So then what about the potassium? What will be the level of potassium in these patients?
Initially, the potassium will be higher due to the potassium will be shifted to the extracellular fluid. So it will be higher.
Hyperkalemia, one word, ma. Please try to answer in single word. The four things you have to remember: dehydration, hyperglycemia, high anion gap, metabolic acidosis. Metabolic acidosis, not respiratory. So include always metabolic acidosis and hyperkalemia. These are the four things which will happen. Then if you say these four things, the examiner will shut his mouth. There is no other question to ask. So how do you treat this patient?
First, we should correct the dehydration.
Hmm.
Then we should correct the
How,
we should
how,
correct the
how?
glucose.
Just don't say vaguely, I will correct dehydration. What is the fluid? How much you will give? What is the rate at which you will give? You have to say all that correctly.
Yes, sir. Sir,
What is the fluid of choice?
fluid of choice will be NS,
Normal
0.9%.
saline. Don't say NS in the exam. Normal saline, finger lactate. Don't say NS, RL. All abbreviations will not be liked by some examiners. So
Yes,
always say I will give 0.09% normal
0.9%.
saline or
Yes.
ringer lactate or plasma light. Some people are saying that balance all solution. I don't like that word at all to be told in the examination because some examiners get angry. So they have to be very specific about it. Okay. So I will give 0.9% normal
Normal
saline.
saline. Yes, sir.
Okay. How much you will give? What is the
In the first hour, I'll give 1 to 2 liter of normal saline. Then in the second hour, I'll give 1 liter of normal saline. Then the third and fourth hour, I'll give around 500 ml of per hour of normal saline. Then in
right?
subsequent,
Wait. What is the contraindication for giving this high volume of normal saline in a diabetic patient for correcting the dehydration?
sir,
Is
if
there any
the
restriction
patients,
or caveat or precautions you have to take? Can you give it for all patients routinely like this?
if the patient is having heart failure, then we should.
Very good. So that is you must rule out congestive heart failure present in the patient before thinking about this. That caveat, all the precaution also should be told. Okay. So in a normal myocardial function patient, you can give this amount of fluid. So that is dehydration correction. What will
Yes.
happen? The common question they ask you is what will happen if you give too much of normal saline, like say 2 liters, 2.5 liters? What is the metabolic derangement that normal saline
Hyper,
can produce?
hyperchloremic metabolic acidosis it will
Metabolic
produce.
acidosis. It aggravate the metabolic acidosis. So the maximum you can give is 1 to 1.5. Don't exceed that. Okay. So give that. What is the indication or what is the clinical sign of your correction of dehydration? How do you know that you have given adequate fluids?
So the heart rate and BP will stabilize. The signs of dehydration like dryness of mouth, skin turgor will be back to normal.
Hmm.
Uh,
This is the most accurate indicator of correct rehydration.
CVP will be normalized.
Physiologically, ma.
Urine output, sir.
Urine output. Always catheterize the patient before you start the treatment.
Yes.
Initially, he will not have any urine because he is dehydrated. Yeah, once you start the rehydration, give adequate fluids, patient will start secreting urine if he has not gone into acute kidney injury because of long-standing dehydration. So the presence of at least 0.5 ml per kg per hour of urine output is the best indicator of your treatment of dehydration. Okay, all the skin turgor and other things are all variable things which will not be accepted. Okay, this is the best indicator to say that you have treated the dehydration correctly. Right. How will you choose the, how will you correct the hyperglycemia? The second problem.
Hyperglycemia, I'll first give a start dose of 1 unit per kg. Start dose of insulin will be given, and then I will
1 unit or 0.1 unit?
so
Suppose
0.1
patient
unit.
is, please correct, remember that. So 1 unit means you will be giving 70 units of insulin. Okay,
Yes.
that is too high for a 70 kg person. 0.1 unit of insulin, so that will be 7 units. Always try to remember some numbers so that you don't make a mistake like this. So 0.1 unit per kg per hour is the first dose, so 7 kg. Then what will you do? You
Then
give IV or subcutaneous insulin?
the IV.
Always IV. In a patient who is dehydrated and hemodynamically unstable, the muscle flow will be very erratic, so absorption will not be good. So always IV should be given, right? So you give IV, then how do you check? Let us say the starting sugar was 400 milligrams.
Yes, sir.
How do you want to
Hardly,
decrease the sugar?
so hardly I'll
Then
check the
immediately
sugar.
bring it to 120 from 400.
No, sir. Then
How much,
hardly I'll
how much you should reduce per hour?
Per hour we should reduce around 50 to 70 mg.
Excellent, very good. So gradual reduction is very, very important. Why? Otherwise, what will happen if you drastically reduce from 400 to 120? What can happen? Which function will get affected?
Brain.
Cerebral function. Okay, patient will have cerebral problem, edema and other things. Okay, right.
Yes.
So that is the way to correct the hyperglycemia. How do you correct the potassium?
Potassium.
What will happen to potassium?
Potassium, after correction of dehydration, the patient may go for hypokalemia. So that time we can supplement
Is it
potassium.
only because of hydration the potassium reduces or some other reason also?
Insulin, because of insulin therapy also.
Insulin also drives the potassium back into the cell. Okay, both the reasons you must say. So that will cause hypokalemia. So from the second hour onwards, you measure the potassium and start supplementing potassium also. What is the dose of potassium you will give?
So we can give 20 to 30
No,
milliequivalent.
20 to 30, 20 only, 20 milliequivalents per hour. No 20, 30, 40 like that. It is a standard dose of 20 milliequivalents per hour is the dose. Okay. So gradually increase the potassium like that. Monitor both potassium and sugar hourly. Okay.
Yes, sir.
Every hour you must measure both these things and bring it to normal. Why you call it as high anion gap acidosis? How do you calculate that?
Because the unmeasured anions will be more in.
Will be there. Okay.
That's
So DKA treatment you should be very thorough with and you should be able to answer all these questions. So luckily this patient does not have DKA. He is not in severe sepsis. He requires a wound debridement. How do you manage this patient's anesthesia?
Sir, I will prefer to give regional anesthesia for this patient.
Can you give an
Because
epidural block?
epidural can also be given, sir. We can give a combined spinal
Whenever the
epidural.
question is asked specifically about the technique, you should always remember there will be a catch in that question. Whenever there is a distal sepsis, epidural block is contraindicated because it can produce epidural abscess. Okay, whereas a single shot subarachnoid block is not contraindicated at all. So please don't mention that you can give epidural for a foot, infection or sepsis case. Epidural is contraindicated. All other types of anesthesia you can give. Okay. So single shot spinal is the commonly practiced technique by most of the anesthesiologists to
Yes, sir.
manage this particular thing. Supposing he has got features of autonomic neuropathy
Yes,
and you
sir.
don't want to risk giving a spinal, what are the other options?
We can also give a ankle block for this patient.
With the infection around in the foot, will you give ankle block?
Better
Please,
to
please remember the answer. I mean, think about the answer before you spell it out. Okay. With so much of sepsis, foul smelling is the description. Ankle block, if you say, examiner will jump to the roof. Okay, don't mention that at all. Ankle block should never be mentioned in a severe sepsis. It is indicated only in dry gangrene or non-infected wounds for trauma cases. Okay, ankle block is not at all the ideal choice if there is a surrounding sepsis in that area. Right, that is ruled out. What are the other options?
we can
Then if
also
you
give
commit ankle block, the other question they will ask you why you should not give ankle block. They will say it is contraindicated. Then they will ask you why you should not give ankle block for an infected case like this.
local
Ah,
infection.
local infection is there. You are not supposed to give. Why? Will the local act if you give a
No,
block there?
no, sir.
So the pKa and the pH of the area, the pH will be very acidotic. So the
Yes, sir.
pKa will not match that and the drug will not act properly. That is the answer that, so you are unnecessarily getting into trouble by saying all these things. Okay, so you must avoid all this to succeed in your examination. Okay, right. So you
Yes.
can go for proximally. What are all the nerve blocks you can give for a foot surgery?
We can give a popliteal nerve block.
Excellent, very good.
Along with that, we can also give
Have
a
you ever given or have you ever read about popliteal nerve block?
yes, sir.
You have seen a popliteal nerve block? You have
Yes,
given?
sir.
How do you
Ultrasound
do
guided
that?
popliteal nerve block we have
How do
given.
you do that? Tell me, how do you do an ultrasound guided popliteal nerve block? What is the position of the patient?
The patient can be in prone position or even in lateral position. We can give a popliteal nerve block.
The best advantage of popliteal is patient can be in supine position itself. That is the most important advantage of popliteal nerve block. Can
Yes.
go from the lateral and then try to reach the nerve. Okay, even in fractures of the limb where it is be painful to move the limb. Popliteal is very great advantage is it can be approached from the lateral aspect in a supine patient himself. Okay, right. There are other approaches. I agree. You can put the patient in prone, in lateral. All these approaches are also there, but it can be done in supine also. Right. What are the other proximal nerve blocks that you can employ in this case?
Uh, we can give a femoral nerve block.
Femoral. Will a femoral
Uh,
alone be sufficient for a sole? The ulcer is in the sole of the foot.
Sciatic.
Sciatic.
Sciatic. You have to combine it with both femoral and sciatic.
Sciatic.
Okay. Okay. So sciatic nerve block, femoral nerve block, all this you should read. All the landmarks, anatomy, and distance, the local anesthetic concentration, volume that is required. Okay. If you are using ultrasound, what are all the uh, how do you identify the location of the nerve? What are the complications? Everything you should be able to say. Okay,
Yes.
right. So after a successful debridement, supposing this patient comes for grafting of that wound, after how many days you can give us repeat? Supposing you do the first procedure under spinal. After
Yes.
waiting for about 3-4 days, the wound is healthy. Surgeon wants to do a grafting. Can you repeat the spinal? How many times you can repeat a spinal for a diabetic wound patient who requires repeated surgeries? Any restrictions on giving a spinal? This is just a question to confuse you. You can give any number of times. Even the same day, you can give 2 spinals, morning 1 spinal and afternoon 1 spinal, because we are using very, very thin needles. So there is no problem. Okay. Unless the patient develops a post-spinal headache after the first spinal, you are not supposed to repeat it. Otherwise, you can repeat spinal any number of times. There is no contraindication at all. You will not get into any problem. Okay. So I'll just again go to show you a presentation just to